approach, as I said, esophageectomy. It can be transthoracic, transhiatal, or a naval invasive robotic. Cross trial, which was done in New England Journal of Medicine, they compared surgery alone for T1B stage, and they said 5 years survival was, oral survival was 40%. Neoadjuvant CRT plus surgery was superior. It was 47% for neoadjuvant chemoradiotherapy. Another study, MERCURY, they compared minimal invasive esophageectomy. They were opinion that it reduced postoperative complications compared to open, it was only 30%. And the 30-day mortality was 2%. High volume centers, it was about 2%. The NCCN guidelines also recommend esophagectomy for T1B due to the lymph node metastasis. Adverse reactions is pulmonary complications, anastomonic leak, chyle leak. So surgery is best suited for T1B tumors, those patients who are fit and with lymph node involvement. Chemoradiotherapy as monotherapy. Its indication is for T1, T2, N0, N1. Those patients who are unfit for surgery or those who are preferring non-surgical options. The regimen is you give 50 grays plus cisplatin or 5-fluorouracil or carboplatin or paclitaxel. Evidence shows 5-year survival for squamous cell carcinoma is 27% with definitive CRT, high local recurrence with surgery 60%, suitable for upper esophageal cancers. Advantage is non-invasive. It preserves the organ is preserved. Limitation, lower local control. There's potential for late toxicities. Various studies is all. Acute events you have esophagitis, late strictures. So it's best for inoperable tumors, cervical, squamous cell carcinoma, post-surgical candidates. When you compare endoscopic resection with surgery, they have indicated that T1 tumors is ER is standard care of care for most guidelines. Esophagectomy shows lower morbidity, better quality of life, lower cost. These are 2 studies. Surgery is versus chemoradiotherapy. T1 tumors, surgery is a gold standard. Chemoradiotherapy is alternative for patients who are unfit. And comparing chemoradiotherapy versus endoscopic therapy, there's limited direct comparison. It is not the first line of therapy, and it's over-treatment for early stage disease. So most of guidelines says T1A is endoscopic therapy, T1B is surgery, and chemoradiotherapy is indicated for. So as a summarize, endoscopic T1A, surgery T1B, and T1B chemotherapy and those who are unfit for surgery. Comparative studies have showed that similar survival, low morbidity with endoscopy. In surgery has better control over CRT. There are no randomized control trials comparing any of these 3 in early cancer. Let's just skip all this. NCCN guidelines is T1A is preferred is endoscopic resection, alternative is esophagectomy. For T1B esophagectomy, you should consider chemoradiotherapy if it's not a surgical candidate. ESMO guidelines same, endoscopic therapy for T1A, T1B surgery, all the same. The consensus, yes. Okay, as is a consensus, first line treatment for T1A is endoscopic therapy. Surgery if endoscopic resection is not possible or suitable, and chemoradiotherapy is not indicated. For T1B, it's in selective cases for some weak tumors, and the standard of care surgeries, and only chemotherapy is only for unfit patients. Recent studies, as I've already discussed, the Sinod trial, the cross trial. And emerging trends is organ preserving strategies, advanced imaging, you must use US or PET-CT, and immunotherapy combinations. Limitation of the current evidence is, we have limited RCTs comparing the endoscopy, surgery, and chemotherapy. Most studies focus on combined modalities. There's heterogeneity in tumor histology, and we need long-term follow-up data on endoscopic outcomes, and limited long-term data on ESD. Just skipping all this. These always patient-centered consideration. Factors influencing choices, the tumor stage, the histology, patient performance, patient preference for organ preservation. This is a multidisciplinary approach. And quality of life, endoscopy has minimal impact on swallowing. Surgery, quality of life impact is there. There's dysphagia, reflex. CRT is long-term esophageal and cardiac toxicities. So summarize T1A, low risk, you go endoscopic therapy. T1A, high risk, or T1B surgery. Chemotherapy is only in non-surgical candidates. Evidence favors organ-preserving approaches, and need for prospective RCTs comparing CRT in early stage we require. So take-home messages, as I said, endoscopy, T1A is endoscopy. Surgery is for T1B. Chemotherapy, inoperable cases, cervical, squamous cell carcinoma, or patient-referral surgery. The recommendation is to tailor the treatment according to tumor characteristics and patient preference. And the future direction is for organ preservation, and immunotherapy. Thank you.